for our last roundtable. It's critical for patients with rare disease. Access to treatment remains a challenge. To mediate the discussion, I would like to call the doctor and president of the Brazilian Society of Medical Audit, Marcos Santos. At there, he's gonna be next to them. Is gonna be Andrea Bessa, Juliana Regini, Karima Leis, Luis Castillo, Marcela Machado, Romulo Marques, and also Claudia Hirawat. She's gonna be online. That's gonna be the fifth and the last roundtable for the scenario of rare diseases in Brazil. I would like to thank everyone who is watching us online. Unfortunately, I would like to have you all here, but because of the pandemic, we have some restrictions to ensure safety. But we expect that soon we'll be able to see ourselves to be together again. So right now, we're gonna bring a lot of content to everyone who is watching us from home and everyone who is watching us from São Paulo. A content that's very important for future discussions in the scenario for rare diseases. So I'll ask Marcos Santos to start. Hello, Marcos, it's your turn now. I was able to go quickly to the bathroom, and but I got him in time. Let me open here the program. Good afternoon, everyone. My name is Marcos Santos. I'm a physician, radiologist, and a PhD in medical ethics in the University of Brazilian, and that's why I'm interested in rare diseases, and also because I studied resources and pharmacoeconomy, that brought me to study of rare diseases. And as I told, and this field needs a special approach. Currently, I'm the president of Brazilian Society of Medical Auditors. We founded the society. We have 200 managers who are members. And I would like to how happy we are to be able to be part of this discussion and how much we've been learning and see the goodwill that our objectives is always inclusion and technological inclusion so the patient will be able to access this treatment because the patient deserves it. Globally, we're celebrating two rare diseases, the hypercholesterolemia and the atypic hemolytic uremic syndrome. It's a rare disease, a progressive rare disease, and potentially fatal. I'd like to take these tables open to remind you of the importance of raising awareness for rare diseases and the burden they bring to patients and their families. 4% of the medications who have been proven by Anvisa's, in many situations, they don't have access to this medication. Our role is to question these models, lead them to an open debate with the objective to propose clear, sustainable alternatives for incorporation of new health technologies, solutions that enable medication in the SUS without putting anyone's else life at risk. I'd like to start this discussion here asking. Let me look here in the report. I should have printed that. This presentation is clear. Despite the advanced register in Brazil in recent years, rare patients still face many problems in accessing treatment. A constitutional right. Despite advances registered in Brazil in recent years, rare patients still face many problems accessing treatment, a constitutional right. The obstacles still demanding by the rare communities, the damage caused by legislation, the need for collective discussions and solutions for the future ahead. Andrea, we're talking about law, patients' rights, how to turn a legal right into an effective right. What are the main legal barriers for our patients who are only 4% with effective treatment to have access to the medication? Fourthly, to explain, the legal right is what, in the law, effectively, what we're able to provide. Because sometimes you have law, but it's not effective because we cannot apply it. When we talk about the effective right, we have to remind how it was created, how the state responsibility for the state. In 1971, we had to provide to anyone who didn't have economical means. In 88, the right for health it was very different. It came the concept health for everyone, and that was written in our constitution as a basic right. Also, in international human rights conventions, life is a right to anyone. So if you are not healthy, you don't have life. Right now, our constitution establishes the state's obligation for health, and the state is discussing its limits to provide to anyone because resources are scarce. How can we provide best treatment with limited resources? Every day, technology advances. You see that medicine, we're talking about precision medicine, also is evolving, and the treatments are extremely expensive. We're talking about 2 8 million, depending on each situation. Before, shoe was one of the most expensive treatments in the world. It's not the most expensive anymore. It used to be one of the most expensive treatments, and now we start talking about a state telling us that we have limited resources, and on the other hand, we have a constitutional right to health, to life. So we have to choose which disorder has this right. We're gonna talk about severity and how to provide this right effectively. So everybody is gonna go to the judicial branch, and the judicial branch is gonna try to make an interpretation how to make it effective for everyone. How we can practice that? The judicial branch understands that the state has to provide the medication under certain limits. This medication has to be regulated nationally. It has to be registered by Anvisa. The patient cannot choose the brand. For insulin, you had many problems because they were choosing which the brand. That's what they were. That's the same thing is happening with vaccine. But for rare, we had specific issues because those were orphan drugs, and those medications were not incorporated in the Conitec because the the problem is not it's not that it was not effective. The assessment was an economical assessment, but not a medical assessment. It's not in regards to the right for the patient to be. And there were some judicial issues, and patients were able to to start lawsuits, and they were able to to win those causes. But of course, this what we want is to incorporate those treatments so it's easier for the patient to access those treatments. Because when you talk about the legislation, you have access for treatment. You have to remind you that accessing the judicial branch is also difficult. It's also a struggle. Out of 10 people who need a treatment, so only one is able to use the judicial tools. It's overblown, but the access is still limited. Some people can't even speak to an attorney, even a public defender. When we talk about when we speak that to some people, there's so many attorneys, there's so many attorneys. That's not true. There are many people who struggle to have access to attorney to start a lawsuit. And when we talk about the private sector, it's even more severe because the reaction, the private sector has great the reaction. They tell their members that they don't have a right. They tell them those health insurance plan they only cover the hospital because you talk to a doctor and then when you have a surgery you have to pay everything out of pocket. If they don't have knowledge or if they have this eagerness to look for a judicial lawsuit, they have to pay for it because NES doesn't talk about this disorder, and that fight is always present. We cannot deny that health is everyone's right. It has been debated, it has been sacramented. It's the only thing is how to make it effective. And we have our opinions, as anyone has their opinions. What are the problems that we face here? When a decision comes, most patients get a favorable decision, but they're not but the government does not comply those decisions. Or when the government complies, there are some gaps in treatment, and that's a huge issue because there are some diseases that the when you start a treatment, the treatment stops progressing, but when they interrupt, the the disease accelerates, and that's very damaging for the patient because instead of helping the patient, you are you are damaging the patient even more. We had a shoe issue. They bought the medication, it was not delivered for the patient, and they didn't have a shoe. It's very impressive. When you talk about treatments, like they call it the treatment like the hand of God. They are in the UCI. They have they have the infusion, and after 1 day, it's like they are totally fine. In our how we see it, there is a lack of planning, like government planning. It it doesn't. It's not that we don't lack. We don't have resources. How we allocate resources. It lacks transparency. How treatments happen, how they have access, how many patients have access. We used to have access to the patient. Now that we don't, it's not that's not available anymore. So the judicial branch does their part. Patient gets a positive decision, but the patient doesn't have access because they don't get the because the government doesn't not comply with the decision. I would like to talk about access to judicial branch because I've been in some PhD boards and there is some controversy if the access is only for people with resources or if other people also have access to it. Some people that's a I think that's open debate. Let's talk to other people because we're a bit late in our schedule. And I'd like to speak to Claudia now. Claudia, you live in the US for a long time and you live directly with members of Erordis. Erordis? I don't know, the European Association linked to the rights of patients with rare diseases. As a saying goes, the neighbor's grass is always greener. Is the patient with rare disease in the US or in Europe guaranteed the right for the drug? What would be, in your opinion, the necessary movements for Brazilians with rare diseases to also have their right fulfilled? It's a pleasure to be with all of you in the US. They don't have they don't have access for medication. There is not in the US a government health universal health care here. The access here in the US is not something that is a right. You don't have the right for health. In Europe, that's different and different. Country by country, that's different. But I don't know any country that have that in its constitution. You have countries with more or less access, but it always depends in some economical issues. Some countries would say that that's too expensive and they will not buy that for the healthcare for the health national health care insurance, and that's a very complicated negotiation with the pharmaceutical company who developed this product. At some point, they get to a pricing point. We don't know this pricing. We don't know where the agreement came, but that's a process. There are many struggles. That's not a judicial process, but usually you have a space for both American and European patients to have access, and also the even the industry helps how to provide without for no cost, but that's not insured. That's not a right. In order to 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 ensure access in Brazil, I'm not an expert, but my feeling, my experience, in order to understand a little bit more how this process takes place, I understand there is a more effect. It lacks a more effective negotiation on a national level to purchase the medications at a better pricing. As you said, the neighbors has a greener lawn. Brazil does not see itself for how with so many patients, with such a huge population, we have more leverage, more negotiation leverage, and that's underappreciated. A stronger negotiation with this company to reduce pricing would be the first steps to broaden access. Without learning more about in practice how we can do, I understand that the rare disease patients, they I don't think they should need a judicial lawsuit for that. I believe that a doctor should was the one who needed to prescribe that, and the medical department should be able to provide that. I don't think that a judicial lawsuit is the right way. Those are the main points that I would like to highlight here. Thank you for your points. I think that it should be very clear the situation in Europe and the US is very different. I was speaking to a friend of mine, Eduard, who is at Interpharma right now, and we're talking about that. A huge barrier to overcome and to improve our process is negotiation capabilities. In Europe, they have a potential for negotiating and also signing confidential agreements. I- In Brazil, we have, I don't know, 210 million people, 50 million in the private sector. There, it's a great number, and this price negotiation would be a great uh, point. I would like to ask Karine and Marcela. We have the 100 coordinators in Rio de Janeiro and Salvador. Is access the biggest challenge for patients with rare diseases? What are the perspectives for these different Brazilian capitals? What's the situation in Rio and Salvador? Is there something specific for each one? Good afternoon. I'd like to thank you to be here to talk about this issue with you. As I told, there is a coordinator and the hunter in Rio de Janeiro. I'm a professor at the University of Rio. I'm a neurologist. Yes, the first question, yes, absolutely. It's a biggest challenge for the patient, and we have a long pathway because the rare disease patient struggles to find a professional who knows their disease. Not all physicians have the knowledge to understand better these diseases. In some situations, when they have access to a physician, the doctor struggles to conclude the diagnosis. And when you get the diagnosis, how do I access the medication? You tell, we have that diagnosis, there's a treatment, but that's very complicated because we know the benefit, but it's very how is there's a lot of the patient struggles to access the medication. We we hear a lot about cost, the medication costs, the judicialization impact. But I have patients who don't have access to medications, and they are in a hospital for a year, 4 months. How much the system spends in a hyper-intensive uh, in the hospital. So that's also very expensive. Also, mechanic ventilation. They are not able to be discharged from this intensive care. So that's very costly as well. So I believe on the second part of the question in real, the associations have been helping a lot in terms of with the judicial lawsuits. Many many patients in the public sector, they don't even have access to an attorney, so they can access through those associations with their attorneys. In some situations, we can approach law, health, and having the right to healthcare, and also have the right to representation. Thank you so much. I believe that Salvador is very similar as well. Good afternoon to everyone. My name is Marcela. I'm a neurologist in neuromuscular, and we're part of the Hunter. I would like to thank Regina and Casa Hunter. I believe that's a huge problem in terms of medication, but we have two issues. Accessing treatment as a whole, very few patients have access to multidisciplinary and to medication. Access to medication is a big challenge, but access to a treatment is also a tough reality. Karina sees that we see some disease with some medications available. A small number of patients have the benefits, but I believe we have the most expensive ones. For example, for muscular atrophy, and we see a huge problem in Salvador. If they are in capital, it's easier, but the other region, Bahia is a huge state. If they are outside the capital, it's much more difficult. Doesn't matter if it's a drug that's available by either way.
In our state, we don't have this uniformity. It depends on the Secretary of Health to release the drugs that are already in protocol. So patients had a lot of difficulties for access. So what I'd like to call attention is in our area is that sometimes we don't have a way to get this medication. Sometimes the patient receives the medication, but they don't know it, and that they say, "Okay, where are we gonna take the drug?" And I think that is also a national problem, especially in large states as Bahia. The problem in Brazil, a country the size of Brazil, I think that's also a bottleneck. So now we're going to have Juliana. Juliana, you have a unique perspective in terms of rare disease. We know that um, some social service people have access to information that we don't have. What are the main differences that you could see when we um, receive a rare disease patient or an oncologic patient? What does a rare disease patient has that is different from other patients? Thank you for the opportunity to be here from the social service perspective. Could you get closer to the mic? I think that the journey of every disease, when you have, for any patient, we have a very difficult journey. So, especially for rare disease patients, we can see some important issues. First of all,
Understand and reflect on
um,
the family
think with the
responsibility
family what is the best strategy,
for searching this
where
treatment.
we can get this treatment and diagnostics. We see the research of our caretakers. We've talked about that, and we need to think about those caretakers who get in debt to have better health options. So we need to reflect with the family and to be able to wait for the time that it takes the national health system, because once they get there, they're going to have a better treatment. So that is something very important to think about in terms of rare disease. Another important thing is Dr. Karina, Dr. Marcela talked about this medication and access to hospitals. And I think when you think about treatment, I think it's important for the patient. And sometimes the patients had to go through different services, and because they go from one place to the other, and they're looking for better services and don't have a single place where they can, receive everything. And sometimes they have to go around, to looking for services, and without knowing that if the health professional knows, or uh, the social worker knows about actually the health professional don't know about the disease. But now us, sometimes we can help because the patient, sometimes they get to us without the authorization. They don't have access to the benefit because they don't have the doctor's opinion. And sometimes we have to think about how we can figure everything out. But regarding treatment, the right for treatment, that is the title of this roundtable. I see uh, how hard it is to get to the physiotherapist professional, for example, physical therapist professional, for example, and the mother says, "No, I don't think he understands my son." They don't know the need. As a social worker, I don't want to throw uh, a cold water bucket, but I need to tell her that what Hunter had done. It's the social working services that we can provide quality services for our patients, and send and make they understand what rare disease are. So we need to talk to other organizations that don't know about rare disease, but they are in the health. Uh, um, they work with health. So yeah, I think it goes to reference centers that we just talked about. There's no way to get into a situation as we don't have many people. It's rare, so and we don't have a large number of specialists to understand. So reference centers are a definite need, and I'm really uh, I like touched to know that this center is gonna be launched in Porto Alegre. Now I'm gonna pass the floor to Luis. Luis represents the pharmaceutical industry at the table. He's one of the most important stakeholders who answers to some of the progress that we've had in the past few years. We are we've graduated like 23 years ago, and I remember many patients, treatment patients that now we can see very effective treatment today, like thanks to questions, to research, and from the pharmaceutical point of view, we've talked a lot about shared risk and new models with the state. Uh, how do you see uh, the industry right now? How have the industry received these proposals? And in your understanding, what are the main challenges for this new model? I love this question. And how the new model can be incorporated. As a industry representative, I think it's part of our role to be here. Dr. Marcus, when you talk about shared risk, from my point of view, and not only mine, but my colleagues as well, shared risk is um, one model. We have models that are more complex, others that are not, and we've talked about that. The role today of the pharmaceutical industry, different from Brazil, is different from NICE, because NICE, the industry has been dealing with NICE throughout the process of assessing technology. And throughout this conversation, we have innovative models. And in Brazil, what we can see is that the industry has played this role or talking to the payer to make these models available for patients. And we remove the load that the new treatments have because they do cost more than older treatments because of the type of treatments that we have. We have different technologies. Um, Today, thinking about the industry, how can we go after the payer? How can we go for models to keep the sustainability of the system and allow access to this patient? Thinking about the array of patient, uh, it's not going to only be affected by the the patient. We've seen many examples of how this rare patient will be affected by this system. We are the engine, and the industry open for that. The main bottlenecks here for access models, we have different levels. You have the federal, state, and municipal levels, and we have law projects that are dealing with that. But there are some things that are possible, and I think that's the important thing. We cannot, thinking about us as an industry, we cannot wait with our hands crossed, our arms crossed. There's no magical solution. There's no standard solution. Together with the public government, the industry need to sit down to see how they can meet the needs of a certain model, because the state ended up paying part of the treatment. So if we don't, if you're not able to co-create these models, we're going to end up failing. And who's going to lose? The patient that will be hospitalized for 1-2 years, bad quality of life, with a product that can release this patient from the hospital. So I think it's a complex situation. The industry has to bring this to the manager, being it the public or private manager, a public manager with the governor or the private sector, but it's a very important element. But it doesn't happen all the time. What is important to us is to encourage. It's little by little, every grain of sand, every day is a new day, every stage is a new stage, and it's a continuous work. And at the end, when we realize that everything has worked, we managed to bring a innovative treatment like the one that was in Europe, now in Brazil. It's very satisfactory because we know the impact it has in the life of the patient and the doctor and the family, the caretaker, all these ecosystem that is impacted. So you're saying that not always we have this initiative, but in reality, I think this initiative is going to prevail. One way or the other, the regulation needs to change. Otherwise, you're going to have what we've seen in the pandemic with temporary measures that generated debate. We need more than one day to talk about that. But reality will bring this initiative. As Karina said, you mentioned it pretty well. We have to think about the complete ecosystem, including the costs of not using all medication. I think what you said is very interesting because what we've talked about throughout the day, rare disease, we cannot not wait for stage 3 with 5,000 patients. We don't have them. So it leads us to more uncertainty, more risk, and it's fair for all stakeholders to share the risk. And we need to develop. We have some legislative arms or the private sector. We've talked about the what happened in the U.S. We have the same pricing system for like ages, and we need to progress. We need to advance that. Now I'm going to pass the floor to Romulo. Romulo, you are the director of the Brazilian Federation of Rare Disease, Raras. We've been following this topic, this subject in Brasilia, my city. For almost 2 years, we've been suffering the pandemic, and we, the pandemic actually sequestered the attention and resources and efforts. Can you talk about the impact of pandemic in access? Not only that, but can you see benefits from this sanitary crisis for patients with rare disease? Thank you. Thank you for the provocation. Thank you, our fellow panelists, all of you here today, the here in person and those virtually. I'm really pleased to be here taking part of this panel. I want to highlight that this panel is so important because each one of us showed their experience, their point of view, and I'm going to present the point of view of a person, of a father of a rare disease son, an hemophilic. I'm talking about the position, the intent of the access of families with hemophilia and other rare disease in the search of something better for their kids. And it's easy to highlight that if families are engaged, the more the better, or less bad the life of the patient is. So following your provocation, I think it's very important. Um, Issues related to Brasilia, being someone from Brasilia, I'm going to tell you a little bit about the dynamic of our federation, how we work. In Brasilia, the role of the directive of the committee, the board of directors, let's say, put it that way. We are searching for the access for the executive power, Ministry of Health, other ministries, chief of staff, and mainly the executive and some the legislative power. But I can tell you, and it's easy to see that the pandemic has affected the access. And when you talk about access, it's very broad, of course, but everybody talked about something: access to drugs, access to hospital. Um, I'm talking about access to the public structure to guarantee the public policy. And that's our role. If you read the 196, it's the a duty of the state through political policies. Exactly, exactly. And we can witness that, the limitation, the restriction of public bodies, so we can provoke our demands, and can we make them happen and finally have them served. Home office work, difficulties for access, communication through email, video conference, in person. Of course, it's better that way. And we have this perception, access in this political context in Brasilia. Brasilia is bubbling. It's alive. Do you live in Brasilia? No. But I'm living in Guyana, but I'm still a citizen of Brasilia. Public policy to health. There was an impact in this context, access to the politician, to the policy, yes, but you have never discussed the evidence. Now I have a lot not a specialist. The discussion has been positive. No question about that. Now I'm going to thinking about the benefit. I'm not talking about benefits, but opportunity. These difficult times, they bring opportunity. They show us some hope to have a better future. But it also brought some opportunity for us to innovate. All of us somehow innovated regarding rare disease, better treatment for their rare patients. That's crucial. Opportunity to renew, to rebuild. Telemedicine is there for that. Video conferences, they are all alternatives. My dear Ariadna just gave me a challenge, and I need to end this roundtable at 6 p.m. But I'm gonna ask you all to be very brief in your answers because I don't want to lose the opportunity to pass the floor to all of you. So go back to Claudia. Claudia, the word benefit doesn't come from, it's not out of the blue that we are bringing it. It came from David Feigenbaum, a doctor and a patient with rare disease, and he is famous for the book Chasing My Cure. Dr. Feigenbaum has visible gains. All simultaneous efforts and the involvement of companies that will benefit, could benefit rare disease patients. You're on mute, Claudia. I think the collaboration among many countries is unique to the pandemic. But throughout the pandemic, people got more flexible. It was a worldwide adaptation. I think this collaboration will have lots of effect in all areas of the medicine, including for rare disease, more access to clinical treatments, more access to conferences and information, more dialogue on the international level. Communication is key for people with rare disease. And yeah, I think it's going to happen. Thank you, Claudia. You have 5 seconds, Luis. Listen, Dr. Marcus, can you talk about access? It's a complicated topic. And what I can say is that from the industry point of view, what I can tell you is there is a concern in making the access to drugs. When you have this research and development and all the investment made in research and development, it doesn't matter if at the end of the day the patient cannot get the medication or the drug. I think that's very important. And that permeates everybody in this panel. What I can tell you is that this concern is real. How can we model all of that? I'm going to leave you a challenge with no answer. You had a huge role, and the main difficulty, at least from what we've seen, is that in rare disease we need real life. I spend like 30 or 40% of my time filling out forms. I'm not complaining, but what I'm saying is that it's hard to get a database of our clients to understand our clients if you have everything. I know, yes, you're right. We have a long way to go, Dr. Max. We have a lot to improve. I think that's a focus. It's a long way to go. And when you talk about rare disease, the N of patients is smaller and smaller. They demand more attention, and the role of industry, uh, as much as we can, to provide everything we need so that the manager feel comfortable in what they do. And there are ways, there are mechanisms to for the manager to feel more confident, especially when we cannot provide all the information. This is a shared risk. Shared risk is nothing but I guarantee the data I'm presenting. As long as I'm going to remove the risk, if it doesn't reach the target that I'm saying, me as a lab, I'm going to provide the treatment. I'm talking about data collection. This is our problem. We've developed software. The industry has something here. I'm bringing some alternatives because from my point of view, this data collection is something that we can have on the midterm. We have some alternatives. And that's what I want to bring here today. I agree with you. We have the challenge. We have to sit down and take it to the representative because real data collection needs to have some sort of control, and that is very important. It doesn't matter the data if they're not quality data. If you have a study full of hosts, doesn't really matter, but we need to pay attention. The industry need to pay attention to that as well. Thank you, Luis. Andrea, time is a very important factor. Why? When you talk about disease, most of them are multisystemic, regenerative, and progressive. How sensitive it is in terms of access to rare disease. Have you been through another reference from other countries with a lawsuit? Well, Casa Hunter has a role. Not that you cannot judicialize, but we defend that it's not the best way. The best, as you said, the federal constitution says that access to treatment is going to happen through public policies. Casa Hunter's battle today is for the implementation of public policies for health. This is the best way, the quickest for the patient. Legal process, a judicial process takes 8 to 11 months. It's a lot of time. Many patients don't have the time. Or it's for in the management sphere, the doctor prescribes something and the public and the government had to fulfill this prescription. It will be easier. We say that about the public health. We need to invest more in education, in technology, in research. Without investment, everything you are saying is going to go down the drain. Another thing, we need political will. It's not lack of money, it's lack of political will. Lack of political will to accept that laboratories should break a pattern, make the drugs cheaper. As they're doing in COVID, we managed for COVID. Why we cannot do it in other cases? So there are many ways, and we need political will. Make it real. It's not the judicialization is not going to solve this issue. It's a restricted access. And for me, this access is prioritized. And we can talk about later on. I defend the National Health Service in Brazil, SUS. Their legal department is perfect. Other countries recognize that. We have something similar, and that is England. But they don't have the bureaucracy. They have investment in research. They break patents. They don't have the judicialization because the cost is too high for the government. Very high. We don't want this. For the patient, that is not good. What is good for the patient is for the doctor to have access to the state, regardless of the medication, regardless of the drug, the treatment, the tests. And for that to happen, we need public public policy in health. And our system must be defended because it's wonderful. It's the only thing, there's no political will to be implemented the way it was idealized. Thank you, Andrea. We are I'm sure that we could stay longer here. The area, the people have told me that I have to go. I have to go. Uh, I tried to see who this question was from, but as complex as access to treatment, sometimes access to diagnostic is very hard. Here at Santa Cordero, are talking about genetic sequencing. I like to ask why we don't have it available for amyotrophic lateral sclerosis with the mutation sequencing. According to Sandra, her husband had it. He lost um, two brother-in-laws. She knows that it's genetic, but to get to that stage, the disease had already taken like 12 companies in her family.
Does anyone want to say something? Let's talk with the neurologists. It's a matter that we don't have enough investment in research in our country, and and patients struggle to achieve reference centers. The primary doctor has to identify something that he's not able to diagnose and refer to the right place. In Ella, it's a very severe disease. It takes a long time to arrive. They go through many specialists, five or six doctors before diagnose, and they arrive very late. We don't have exams available because have difficulties to access. We have very few reference centers where they could do this genetic testing. Karina, I'll say that most patients who have who has the disease have when the progress she also talks about the progression. If it takes too long for the diagnosis, we lose the patient's life. Regarding this disease specifically, the greatest contribution is the multidisciplinary team. We know that at this moment the medication available, the la- la- the afterlife is not the the multidisciplinary team is better have has better outcomes than the medication. I would like also to highlight that there is some hope. There is hope. We've been able to get some gene testing with the support from some labs that will help with family cases, and we know the number of articles for medication for this disease. The problem is that this disease is multi-factors. It's very hard to find a medication that will address all the pathology. So we have to identify the mutation and we have to go to the mutation to change that. And the access for this infuser in the physos, in the lumbar, maybe we don't have an access or a center where I can provide this infusion, but I'm optimistic. I think we'll be able to help patients more and more, and they hunt this opportunity that I believe that 80% of the patients with sclerosis amyotrophic, these patients they'll be able to improve their lives with this multidisciplinary team. It was a huge pleasure to talk to you and this wonderful issue here. Thank you for your patience. Have a wonderful Friday for everyone here.